All right. Hello, everyone. Welcome to Project Echo Geriatrics. Happy Friday. We're going to go ahead and get started. We have a wonderful speaker here today, Dr. Elizabeth Phelan, who is often one of our panelists, is going to give our mini didactic today on fall screening in primary care. She is very expert in this area. She's done her research and her work educationally and in research as well focuses on improving primary care for older adults, and a focused area of that for her has been fall prevention. She's the founding medical director of our fall prevention clinic here at Harborview, which was really focused in on what do we do to help prevent all of these older adults from presenting to the ER over and over? What can they do after that to prevent this from happening again? And what can we do to do some primary fall prevention? So she's worked in the clinic for a long time, continues to do that work, and she is going to talk to us today about fall screening.
Thank you very much. That was a very generous introduction. Welcome, everybody. As Kate said, this is a topic that we deal with all the time in our older adult population, and so Kate asked me to focus specifically about screening. So we'll stay on topic and just take questions, allow time for questions too. And I think our case today is about falls. Do I advance?
Yes.
So this is an overview of the epidemiology and the impact of falls, just to set the stage. So falls are a very common phenomenon as people age. 1 in 2 people age 65 or over falls every year living in the community. If you look at people who are 80 years and above, that number actually goes up to 1 in 2. So it's hard to get much more common than that. And falls are actually the leading cause of both fatal and non-fatal injuries in this age group. So, oftentimes people will think, oh, what causes injuries? Motor vehicle crashes, for example. That's actually accounts for a much smaller proportion of injuries in this age group. So it's common if an older adult falls to actually consume medical care, seek medical treatment for injuries. And recent data show that even if they aren't seeking care, that they may be restricting their activity at home because of injuries of various types that may not require medical attention. The cost of caring for people who fall and do injure is staggering, $50 billion annually. And important for us as primary care providers on the front line is to recognize that most, or at least half of older adults never talk to their doctor about the fact that they've fallen. So just by way of definition, to make sure we all understand what we mean by a fall, this is a common long-standing definition: coming to rest unintentionally on the ground or lower level. So important to note here that acute events like strokes, seizures, overdoses, where people may fall as a result of those acute events, those don't really count in our definition. We're talking about falls that are events due to trips, slips, and stumbles. And as similar to the acute events, any kind of acute, overwhelming external force such as being pushed in a crowd, shoved, those are not considered true falls either. So why do people fall? I show patients this slide in clinic often because I think it's important for both our patients but also us as providers to understand the importance of individual factors as well as environmental factors in falls. Older adults tend to focus on the environmental factors, namely things either in their home environment or places in their neighborhood that they may be frequenting. They will talk about sidewalks that are uneven, And of course, those are factors oftentimes. But for people who fall recurrently, it's the understanding that that is probably not just due to environmental features alone, but due to other things about the individual. We can think about those things as underlying predisposing factors, so things we might not be able to change, such as some chronic conditions. Also, aging-related changes do play a role. And then things that we might be able to change, what's been called modifiable contributors or risk factors for falls, such as poor balance. I highlight here some other things that are usually considered things that are extrinsic or in the environment. So medications being a big factor there, and what people put on their feet. And this is not an exhaustive list, but just by means of illustration of those, the need for that interaction of intrinsic, so-called intrinsic or individual factors combining with environmental factors to result in that fall event. So, screening. What does screening consist of? So, unlike, screening for cancer, where you might have to send somebody for a test or perform a test in your office, all we have to do to screen for falls is to ask older adults, and the current guidelines adapted by the CDC and being disseminated nationally through the initiative called the STEADY Initiative suggest that the frequency of screening be at least once a year for all adults in this age group. You can certainly ask more often. People who fall often, as I said, recurrently, and those are the people we really want to target for interventions. So there's no reason you can't ask every visit, but there is at least an opportunity once a year, and things like the annual wellness visit, for example, if you're conducting those with your Medicare age group patients, where you have an opportunity to specifically focus on prevention, where you could bring it up then. So how do you ask about falls? These are 3 questions that are derived from, again, the STEADY Initiative. The first question, have you fallen in the past year? You also want to follow that up with, if they say yes, how many times, and were you injured? That, according to the American Geriatric Society and based on research data, is the single most helpful question if you're going to ask one question. But to pick up people in the primary prevention mode who haven't actually fallen, who might answer no to that question, you should then go on to ask, do you feel unsteady when walking? That will get at people who have not yet fallen but who are appropriate for primary prevention of falls. And do you worry about falling? This is a very patient-centered question that we like because it actually gets at this idea of anxiety or fear of falling that tends to cause people to restrict their activity and to not, not really do the things that they would have liked to have done. They stop doing those things, and that can have a lot of downstream consequences. So there are a few, and I want to emphasize few screening tools out there that are designed for primary care use. And this is one of them. I'll show you a couple of others as alternatives in just a second here. So if you want to actually do something more at the population level, say you're with your patient panel, you want everybody screened, or your clinic decides that they want to do this in a systematic fashion, this could be a nice option for that. It's a short screener, and it was validated specifically for use in the primary care setting, where the validation was using this tool against a geriatrics clinician's exam, history and exam. It is self-report, and it's easy to score, and scores over or at the level of 4 on this tool suggests that the person is at risk. I'll show you the items on the next slide. So it's a pretty simple scoring system. A couple of the questions, the first 2, get more weight in the overall total score. The other thing that was nice about this from the standpoint when it was developed, it tried to get at some of those what we call modifiable risk factors for falling. So leg weakness. Again, the fear of falling, balance problems with questions like, I steady myself by holding onto furniture when walking at home, so-called furniture surfing. So not only does it help you get a score to determine whether this patient of yours is at risk for falls or not, it gets some history going so you don't have to, you can look at this and start talking with them about risk factors right away. This tool I found, I was not familiar with this, but I sort of like it. It was designed for use in emergency rooms. There was one other tool that I chose not to present that was designed for primary care, and it actually is performance-based, so more complicated, I think, for implementing in general clinical practice, where you actually have to have the person in the room and have them perform certain types of maneuvers. This is a simple 2-item screener. And again, it has not been validated for use in primary care, but it talks about the article that describes this validation of this tool, talked about how the advantage here is that it's things that in an emergency department and also understandably in a primary care setting we would want to ask about anyway. So have you fallen more than twice in the past year? And then you can easily look to see the number of medications. And this tool will predict falls in the subsequent 6 months. It's really easy again to score, and you can see that the probability increases with increasing scores. This is one that I wanted you to see, the sit to stand. This is useful because it may be something that you actually observe a patient doing without even having to physically test them. You might see them get out of a chair, for example, if they're in the room and get up to use the restroom, or they're coming into your office and you see them get up from the waiting room. So this is a easy visual test that has a very strong likelihood ratio positive for falling in the next 12 months at 4.3. So if people have to use their arms to push out of their chair to stand up, that is a strong predictor of falls. So while technically it's not a tool, it's a maneuver that may be useful. So what do we do if somebody screens, so-called screens in or screens positive for being at risk or actually has fallen? So the next thing to do is some assessment, and what you're doing there is trying to identify what I mentioned already is those modifiable risk factors for falling, and I've listed those here. These are, again, things that you may or may not have in your armamentarium that you can look back on. For example, you can look at blood pressures, ambient blood pressures, and find people running low blood pressure, of course, but looking for postural hypotension, that is something you may have to have staff time or yourself obtain as part of a visit. So I won't go into all of these different risk factors today, but just know that this is the next step beyond screening. And then when you identify which of those risk factors your patient has, the next step is to be familiar with things you can recommend that have been shown in the research to be effective in addressing that risk factor for falling. So really important for us to emphasize, and we talk about this time and again in ECHO, is making sure we attend to medication. So that's the one thing that we really have control over in partnership with our patients, is which medicines we keep them on. And in clinic, I'm often, most times, peeling medications off. I almost never prescribe medications in these patients. Managing postural hypotension, people can self-manage that. There are strategies, abdominal binders, etc. Medication to volume expand if necessary. I rarely use those. Self-management often helps, along with the reduction in medications that may be a big contributor to that. Strength and balance exercises. There are a number of programs now that have been shown to be effective in addressing strength and balance deficits. The CDC has a nice compendium that's called the Guide to Effective programs, something along those lines. I don't have a screenshot of it, but maybe as a resource we can send that out, listing and summarizing the various and sundry different effective strategies, including exercise programs that have been tested and shown to work for falls. Just to wrap up, know that this systematic review found that what encourages older adults to engage in behaviors that will help them reduce their risk of falls, far and away the most important thing is your recommendation that they do so, along with some of these other reasons here. We focus on improving, or restoring function when we talked with people about what their treatment plan should look like, and this often helps if we put in the context of the things that they used to do that they enjoyed, that they've stopped doing, but they would like to get back to, if possible. So just a couple summary slides here and we'll wrap up. This is based off the American Geriatric Society algorithm summarizing the screening and management of falls. They have not produced a guideline since 2011. I haven't heard that one is going to be forthcoming. The U.S. Preventive Services Task Force just released an update, and I'd be happy to take questions about that. It was long in coming.